the Department of Healthcare Access and Information webinar, Designing Hospitals for Wildfire Smoke, HVAC Strategies for Resilience and Readiness, brought to you by the Hospital Building Safety Board's Education and Outreach Committee. This is the second session of the HCAI Design Guide for Planning and Preparing for Disasters webinar series. Some of the topics that we'll cover today include fundamentals of wildfire smoke, key HVAC strategies to reduce smoke infiltration and maintain building pressurization, developing a smoke readiness plan for hospitals. We've made today's presentation, as well as the HCAI Design Guide for Planning and Preparing for Disasters, available to you. Look for the section labeled Handouts or Materials on the right side of your screen and click the files to download them directly to your device. We're scheduled to be here for an hour, which includes a Q&A session at the end. If you have questions during the presentation, please type it into the questions panel of GoTo and we'll answer them the best we can. But please make sure to keep your questions generic. If the presentation experiences transmission difficulties, please log out and log back in using the same login information sent to you by GoTo when you registered for this webinar. And if we have problems on our end, we will do the same. In coordination with AIA California, you earn one AIA HSW learning unit by attending the entire presentation. If you have questions regarding continuing education units, please contact AIA California. A certificate of completion will be emailed from GoToWebinar to registered attendees who logged in and attended the entire presentation. Certificates will not be available from HCAI. Staff members from one office should register individually to receive separate logins and individual certificates. So today's presenters are Samantha Miller, Senior Architect at the Department of Healthcare Access and Information, Office of Statewide Hospital Planning and Development. Mikhail Fuchs, Mechanical Engineer and Director of Engineer at Pan Pacific Mechanical and a member of the Hospital Building Safety Board. And last, Abdel Darwich, Mechanical Engineer, Principal at Gutman and Blauvet Consulting Engineers and Hospital Building Safety Board Consulting Member. Once again, thank you for joining us today. And without further ado, I hand the presentation over to Samantha.
Thank you. Hello, everybody. Thank you for joining us today. My name is Samantha Miller, and I'm the Senior Architect in the Building Standards Unit of OSHPD. Before our speakers, Abdel and Mikhail, begin their presentation, I'll be giving a short introduction on the history behind this year's webinar series on disaster preparedness. Starting with a little bit of history on the relationship between HCAI, OSHPD, and the Hospital Building Safety Board, or HBSB. A few years ago, the addition of various services to the previous OSHPD resulted in a reorganization and rebranding of the office into a full department named the Department of Healthcare Access and Information, or HCAI. And as part of that, what was formerly the Facilities Development Division was rebranded to the Office of Statewide Hospital Planning and Development. And since then, all of the roles and responsibilities of the former FDB have moved forward as they currently are in place at OSHPD. The HBSB is an advisory board established by statute that advises the HCAI director on application or administration of the Hospital Facility Seismic Safety Act. It also acts as a board of appeals for hospital facilities in regards to seismic safety and fire and life safety issues. The board is comprised of 16 appointed members, 6 statutory ex officio members who represent different state agencies, and 3 additional ex officio members, all who are appointed by the HCAI director. The HBSB maintains close contact with professional groups and industry organizations. It also brings to the attention of the office various changes and emerging issues occurring in the design and construction of healthcare facilities. And that is the framework that got us to the current webinar series. Next slide, please. Moving to the topic of this webinar series, the HCAI Design Guide for Planning and Preparing for Disasters. This guide was put together as a resource to evaluate how past events and lessons learned from them could provide information for future critical events. It provides various scenarios and approaches for designers and owners, allowing flexibility for future design and construction. At the same time, it looks to limit the anything goes practices that were experienced during the pandemic. It ultimately boils down to providing a best practices guide for designing facilities that are best prepared for a future unknown disaster. Next slide, please. The guide applies to new facilities as well as major alterations to existing facilities and tries to provide planning for the unknown. We recognize it is hard to design for the unknown, but that is the goal of this guide. It looks at providing flexibility in various design systems to adapt facilities access, utilities, emergency projects, and so on, while providing flexibility for future care options. Ultimately, it's a design guide that will show that designing beyond code minimum is going to be more and more necessary to be best prepared. Next slide, please. This guide is designed to be used by owners and operators, design teams, local agencies, planners, contractors, and then of course, any others who are involved in planning for future disaster events. Next slide, please. So to expand a little on the history of the COVID-19 pandemic, most if not all facilities were essentially caught by surprise and were struggling to find ways to provide safe care environments for staff and patients. OSHPD was routinely called upon to help mitigate and deal with some of these issues. As an example, how does the facility make everything negative pressure, and so on. So ultimately, and as a result of all this, there was some discussion if OSHPD was going to change the building code to incorporate these lessons learned during the pandemic. So OSHPD assembled a group of people knowledgeable in healthcare design, planning, codes and regulations, and the Emergency Design Task Force was ultimately created. Next slide, please. This group was tasked with identifying not just things related to the pandemic, but other disaster events such as wildfires and earthquakes. Interestingly, it was determined that for normal everyday operations, current code was adequate. But what about facilities that needed to be designed to incorporate or accommodate disaster situations? Next slide, please. And so this design guide also addresses many options to prepare for possible future events. The technology, processes, and lessons learned were incorporated into the design guide and offer options such as switchable air volumes, redundant services, and incorporating new technologies into practice. And this design guide tries to cover all of those things and more. Next slide, please. So with that in mind, this design guide has a great cross-sectional application. There will be a total of 6 webinars that address different aspects and excerpts from the design guide. Today is session 2, expanding on wildfire readiness with a deep dive into best mechanical processes when addressing wildfire smoke. And so at this point, I will turn it over to Mikhail.
Thank you so much, Samantha and Yvette, for the great introduction and teeing it up for myself and Abdel. So for today, for this session, we're going to cover a few different topics. First of which will be some background information about wildfire smoke, what it's composed of, how it happens, and what are the resources that are available to the community for addressing that, and as well as being prepared for it. We're going to go over some concepts of how to protect buildings. We're gonna work through how do we know that we have smoke infiltration or an issue happening. What do we do to plan for it? How does wildfire smoke enter buildings? There are different paths, and there's some misconceptions about that. How do we measure for it? What are some precautions that could be had within facilities? And how do we deal with? We jokingly call it triple Murphy's Law. Something will fail, something will happen, but it also will happen at the worst possible time and in the worst possible way. So how do we make sure as a healthcare facility that we deal with that? So wildfire smoke is a hazard. Normally people focus on the fire hazard itself, and they really don't fully appreciate the smoke element of it. It's not local. It affects facilities local to the fire worse, but it certainly has a way to propagate hundreds, if not thousands of miles across areas, and I'll show you some examples of that in a second. But it's really something that needs to be focused on for prolonged impact to facilities. So I'll give you some examples here that have happened in the recent past within California. 2018, the fall of 2018 in Sacramento, this fire was started at a campfire approximately 90 miles away from downtown Sacramento. As you can see, the effects visually on Sacramento were substantial, and this continued for about 11 days. And at the worst of it, Sacramento registered as the worst air quality on the planet at that particular moment in time. So really, really significant impacts to a specific location with surrounding wildfire. Next slide, please. Again, another instance in San Francisco in 2020, Orange Sky Days. This was started by wildfires in the August and North complexes outside the city. A really substantial impact to the San Francisco area within that period of time. So again, we're talking about prolonged days of impact to facilities. Next slide. And then, of course, as many of us lived through the Palisades and Eaton fires last year, large-scale impact both in mountain or foothill adjacent communities as well as urban city areas with the proximity of large-scale neighborhoods and cities being built very close to areas with increased wildfire danger. So these are just some examples of what can happen in surrounding areas that we deal with, the healthcare facilities that we deal with on a day-by-day basis. And with that, I'll turn it over to Abdel, who's going to go into some more details on this phenomenon, this subject.
Yep, thank you, Mikhail. So we're going to go back to the basics and ask the question, what is wildfire really made of? And the answer is that it's complicated because it really depends on what's burning, the moisture content, the fire temperature, even the wind condition. And it's also getting complicated with what we call wildfire urban fires, like the picture that Mikhail showed in LA. It's not that only the forest burned, it actually jumped and burned an entire neighborhood. And with that, there was a lot of man-made product burning with plastics. And this actually changed completely the chemistry and the composition of wildfire. What we know, though, is that wildfire is made of gases. And in those gases, I mean, you have your ozone and NOx, but most importantly, you have your VOCs. And the VOCs are the most smellable. So when you smell something burning, like even in your kitchen, actually what you're smelling is the VOC. Same thing for wildfire. That's what you smell. In addition to gases, there are particles, and you have carbon, you have heavy metal. It's mostly all sizes. I mean, and weight distribution, it's mostly PM2.5, which are actually the most dangerous. Recent research is showing us now that on a particle count, actually, they are much smaller, getting into PM, smaller than PM.3 even. What is PM2.5? This is what we call particulate matter that are smaller than 2.5 microns. If you look at the human hair, it's about 50 micron. PM10 is actually 1/5 of that, and PM2.5 is the quarter. Again, just want you to imagine how small PM2.5 is. And because of that, as you can see, it can penetrate deep into the human lung. PM10 doesn't penetrate much. PM2.5 and even PM1, they penetrate deep, and as such have, they have very tremendous actually health impact on humans. Canada and especially British Columbia has been, they have 3 or 4 times the forest areas as California, and they've been dealing with wildfire a lot. So we've seen a lot of research and clinical data coming from them, and all the research is basically indicating that wildfire smoke is dangerous to human health. Whenever there is a smoky day with wildfire smoke, you have more people reaching out to get medicine, more medicine dispensation. There is more people going to the doctor with physician visit, and you can see it in red. And even there are more people dying, and you can see the mortality rate is more whenever there is wildfire smoke. And that's not only for respiration related diseases. There was also an uptick in cardiovascular diseases as well, as you can see on the right side. And again, part of the research that was coming from British Columbia is that the acute care are not linear. And as you can see, as I mentioned, PM 2.5 is a great indicator of wildfire smoke. And the average usually is about 25. And once you have wildfire smoke, it starts increasing until it reaches about 250 or more. But the first part of the increase, and you can see it on the left side of the graph, is very exponential. And then once you get above 100, start to get more linear. And again, the takeaway from this graph is that once people start to choke, they start choking. And if you want to do something, it's not enough to reduce the PM 2.5 from like 250 to 100. That will not be enough. You have to really be in the blue or in the yellow zone in that graph. Again, continuing with the basics, I mean, many of us who are HVAC engineers probably know that, but for those who are not, when you talk about filtration, air filtration, we really have two big families of filters. One, we call them the particulate filter, and these work by interception. You have some fiber that are interwoven. I mean, you can see this in probably in your home filter. And and these basically work by intercepting particle. And if the particle is larger than the distance between the fiber, it will be stopped. If not, it will pass through. Typically, when you hear the word MERV or HEPA in your hospital, that's usually a particulate filter. The second family is what we call gas phase, because gas particle or molecules are so small that they will pass through any fiber filter or particulate filter. So gas phase are totally different. We have some filters that are physical. Basically, what we mean by physical is that they're not changing the gas composition; they're just absorbing it like carbon. And the second is chemical, or what we call reactive. So they are like all the new technologies, the PCO, the needle point, all are those reactive. So they are reacting with the gas to change it. And these are the two sub categories of the gas filter. So the information that Mikhail and I are gonna present today comes from two sources. One is the HCAI design guide for planning and preparing for disaster. I know it's a mouthful. So going forward, I would just refer to this publication as the design guide. Samantha did hint to that. Going into more details, I was part of the emergency design task force that actually wrote this guide. So we work on this guide between 2020, 22. It was, as Samantha mentioned, initiated by the pandemic. And then it was published in 2024. The Wildfire is in section 7. You can refer to the guide. But as Yvette mentioned, it's actually available on the HCAI website. And that guide actually is planned to be updated. We have new data, as I mentioned at the beginning, about wildfire smoke, and that will be used to update the data in the guide. The second publication is ASHRAE, the new ASHRAE Guideline 44. So when ASHRAE started realizing that something need to be happen with wildfire smoke, they started the committee to draft this guideline back in July of 2021. The committee I was part of the committee. We took a detour. We published a white paper in 2022 because we wanted to do it before the wildfire season of that year. And that actually white paper was used as a basis for the design guide, for the HCAI design guide. However, once the design guide HCAI work stopped, Guideline 44 continued for another 3 years. And as I mentioned, there was a lot of research surfacing. So we had access to a lot of new data, and especially that Guideline 44 committee was, I would say, half scientists, half engineers. So it was a very, very nice committee, and we tried to bridge the gap between the science and the engineering aspect. Sometimes actually do give the access to Guideline 44. It made it free after the LA and the Canadian fire. Last time I checked last week, it's no longer available for free, but I did actually put a request to ASHRAE to make it, because this is a public safety guideline, to make it free. So when we look at how can we protect the building, especially a hospital or a healthcare facility, from wildfire smoke, it boils down to 4 key principles. And you can see them here in the squares. The one, green, is knowing. And you need to know that there is a wildfire smoke. And we're going to talk in more details what that means. Second is planning, which is you see it in blue, and which is basically you need to plan for the wildfire smoke. You can't wait till the last minute to decide what to do. Third is that once there is a wildfire smoke and it reaches the building or the hospital, you need to make sure that you prevent it from getting in. And the last core principle is that eventually some of the wildfire smoke will get into the building. And you need to, what do you do with it? And then you need to remove it. And this is the gray or the last key concept. So let's start with the first one, with knowing. How you know is that, as I in the background information, you've heard me talk about PM 2.5, which is you have to install PM 2.5 sensors. In guideline 44 and as well as in the HCAI guide, we talk about installing PM 2.5 sensor. Usually you have to put it outside, not necessarily in the outside intake, maybe on the roof, on a parapet, or if you have a regional monitor that's close by and you can connect to it, that's another good source to know when your PM 2.5 increase, and as such, you would know that there is a wildfire smoke. Also, you can as well install it in entryways, like in hallway, ambulance bay, and loading docks, because that's the main source where wildfire smoke could enter a building. And if you have, at-risk population or high occupancy area as well, you can as well install PM 2.5 sensor there to know about the wildfire smoke. The second key concept is to plan for it. Wildfire smoke, I mean, you're seeing longer and longer period of significant smoke. And sometimes we can't even tell when is the fire season. I mean, you could get now a wildfire smoke in any time through the year. So planning is the key, because really nothing good happened at the last minute. And this is why in the guideline and the HCAI guideline and in guideline 44, we recommend developing what we call a smoke readiness plan, an SRP. And in that SRP, usually there is 4 parts. Now, for the sake of the time, I would refer you to both the section 7.2 in the design guide or section 6 in guideline 44. It has way more details on how you develop a smoke readiness plan. Like, again, some examples, some question you can start. Well, will the building be occupied during a smoke event? Is this an MOB or an acute care? Can it be evacuated or not? And if you can't evacuate it, will there be an area of refuge in the building? And really, typically, the SRP have 4 sections. One, what we call the preparation, which is the what, the who, and the how much, like what we need to do, who is responsible of doing it, because that's a very important key, because many times there will be like, finger pointing and nobody is lost at the last minute what to do. And typically, if you want to add some more filtration, there could be some financial implication. So there'll be like, okay, yeah, if we go into smoke mode, we're going to be adding filtration pressure drop that will increase the energy. How much will this cost us? The second is this testing. Once you figure out what you want to do, you need to test them or commission them, make sure that all the components and the sensor are working. The third section is that you need to be clear on when to implement it. Is it manual? Is it automatic based on the PM 2.5? For those of you who are HVAC engineer and use guideline 36, guideline 36 now have what's called an outdoor pollution mode, which is basically inspired by wildfire smoke. And the last is that how do you return to normal operation? Do you immediately return? Do you have to do any cleaning for the duct or any cleaning for inside the building before you can return? And most importantly, in healthcare setting, we need to coordinate your smoke readiness plan or the SRP with your infection control group. Now, you have an SRP. What do you do with it? And again, we don't want the SRP to be just a simple bureaucratic document. So you need to let your operation, your facilities know about the smoke readiness plan and be trained on it. Now, for new project, we recommend that you include it in the owner project requirement and in the basis of design, and even include it in your sequence of operation. Have a wildfire smoke mode in your sequence of operation, and make sure, of course, that it is commissioned. With that, now we are moving to the third core concept, which is preventing, and which Michael will show you. Mikhail is gonna walk us through this.
Thanks, Abdel. So, Abdel covered how we plan for it. Now thinking about how we prevent wildfire smoke from entering the building. I think that sometimes there's a misconception that air enters through the HVAC system and then spreads throughout the whole building, and that's the only way in. Well, in reality, there's a lot of different paths. Certainly, HVAC is a big part of that, and we'll get into some of the details surrounding that. But air will find the path of least resistance. It's going to look for doors, for envelope elements like windows or leakage through the envelope in order to find a pathway in. As well as on occupants or any sort of items that are entering and exiting the building. They'll bring particulates within those pathways as well. So a really comprehensive strategy of preventing is paramount to success. The other part that we'll touch on a little bit more as we go along is really pressure is your friend. Positive pressure, making sure that air is pushing out of buildings versus in buildings is really important. And so it's really an operational component as well as design. So let's get into some of the specifics. Thank you, Abdel. So outdoor air intake measures. In the event of a smoke event, you want to minimize outdoor air coming into the building. You don't want to shut it completely off because there's certain health impacts and impacts on the building's operation in totality. Obviously, that there's a sliding scale there depending on the severity of the event. You want to minimize certain sequences and operations within your HVAC system that would increase outside air intake, such as economizing modes. In some situations, healthcare facilities do have 100% outside air HVAC systems, which are particularly challenged in this sort of event. And so having a plan in place for how to operate in a more recirculating fashion, certainly easier to do within a new design when it's thought out and planned for versus a retrofit. But it's something to think about, especially for new facilities within areas of specific fire danger or increased level of fire and smoke danger to weigh against other factors when choosing 100% outside air systems. Making sure to seal ductwork and having that building, again, from a pressure perspective, pushing out, not in, is critical. And then lastly, for any naturally ventilated spaces, having a plan to switch to mechanical ventilation with the appropriate filtration that Abdel started talking about is really key. Next slide, please. Particular focus at doors and entryway locations. As I mentioned, positive pressurization, including the addition of vestibules or other ways to from a space planning perspective to break the dependence on the door being directly into the clinical space is really important. Utilizing air curtains, which are fairly typical for areas already like emergency departments and loading docks that either are at a higher level of infection, how common infection is, like the emergency department entrance, or just dirtier areas like loading docks. I think looking at air curtains in more areas than that to prevent smoke contaminated air coming in through different openings. And then more of a planning comment, and this is kind of speaks to the nature of the holistic approach, is when you're laying out a new building, making sure we understand where prevailing wind directions are coming from. So and specifically impactful wind directions, such as Santa Ana winds in Southern California, making sure that when you're doing the planning, that entryways, especially main entryways, look at that, study it, see if there's ways to avoid it or turn that entryway in such a fashion to really not impact the facility down the road. That's where kind of the thinking about the end result and how the facility is actually operated in the planning stage is really critical. Next slide, please. So I mentioned envelope measures at the beginning. So this is, making sure the project specifications, both from a product perspective as well as requirements for installation and commissioning, are stringent for the sake of reducing smoke infiltration. For existing buildings, there's certainly a process that can be gone down for existing visual inspection, identifying potential challenges and problems. You see some of the thermal mapping that's done in the images on the screen, and then mitigation measures to improve those conditions on existing facilities. And in new facilities, it's really developing that the exterior envelope commissioning plan, and setting leakage goals that are building tight facilities, and avoiding any more easily avoidable challenges when it comes to smoke into your buildings. Next slide, please. I'm going to keep saying it because I know it's repetitive, but it's super critical and important to this conversation. Keep your building positive. Make sure that both from a OPR perspective at the project onset, the quality control reviews that are done throughout a project's design and permitting, making sure that building is positive and balanced. Utilizing your BMS system, there's a lot of really advanced and smart BMS controls that are in a lot of the buildings within healthcare facilities throughout the state. So making sure that early detection, as Abdel mentioned, through additional sensors, and early action, automated action through the BMS system, in order to prevent getting smoke within the buildings, is really important, and something that should be looked at on a regular basis, not just as the building is getting designed, but regularly commission it, retro commission it, and make sure that those aspects are fully functional on a regular basis. So now that we've talked about preventing smoke from getting into buildings, inevitably smoke may get in. So how do we remove the smoke that does get within the buildings? Hopefully a reduced amount if those prevention measures are followed substantially by facilities. So as Abdel mentioned, PM 2.5 level particulates that we're trying to get out of the airstream. Typically, and we'll get into more details in a minute on how we land on those values, but typically that's at least a MERV 13 minimum filter for most facilities, which is really not that high of a bar, given a variety of other codes and standards, and typical healthcare projects go through. MERV 13 is usually where you end up landing for most of your basic filtration within the air handling systems, and so it's not as though you need to substantially impact the performance of your HVAC system in order to achieve that. So I think it would be highly recommended. And with that, I'll kick it over to Abdel, and he'll go a little bit deeper into the filtration selection methodology.
Thank you, Mikhail. So the question is what filter do I need to protect a building or a healthcare facility from wildfire smoke? And again, the question comes back there: do you like math? Because there is a prescriptive and there is a performance way. If you don't like math, you can use a prescriptive, which is as well mentioned in the HCAI guide, and you can just go with MERV 13. And again, especially if you have an acute care hospital, that's easy to do. You'll likely have even better than MERV 13. Other building you may need to upgrade. Now, if you like math and you have an engineer who like math, should be, you can go to the performance method, which is outlined in guideline 44. So the prescriptive is really just putting MERV 13. MERV 13 will stop about 85% of PM 2.5, and that's again on one pass. The more you circulate the air through the filter, the more you'll be able to stop the PM 2.5. And again, as I mentioned, PM MERV 13, especially if you are designing an acute care hospital, should be attainable. Even for other building now, with all the parking requirement, I see it that it's a very doable very reachable, I guess, MERV rating. Now, if you want to do the performance, there is an equation. Again, for the sake of time, I will not put it here, but there is an equation in Guideline 44 that you can, based on the outdoor PM 2.5, you can, and the indoor and the airflow and the filter efficiency, you can fix 3 of those and come up with with the third. Like you can, if you have an outdoor PM 2.5 and you want to set a goal for the indoor and you want to know what filter efficiency will work, you can use that equation that's in Guideline 44. The most important is the frequency of the change. Guideline, actually, there is an example actually in Guideline 44 and the calculation method for you to estimate how frequently you need to change your filter during the wildfire smoke event. Irrespective, though, if you do the calculation or not, expect that you're going to change your filter very, very frequently. I mean, I've seen facilities having to, again, depending on your proximity of the fire and the wind direction, I've seen facility having to change them as soon as 2 to 3 days. So you're talking about days versus like the normal schedule, which is 3 to 6 months. And sometimes the question is always, well, can a filter fail? And yes, it does. I mean, it cannot keep holding dust unlimited in an unlimited way. Each filter has what we call dust holding capacity by weight. So once that weight is reached, usually by wildfire smoke, PM 2.5 or the other particles, the filter and the frame is not designed to handle that much weight. It would just crumble down. Again, one of the other things that we noticed when we were doing some site surveys is that sometimes instead of upgrading your filter, it's good to check if you have leakage, especially if you have old HVAC systems. Checking your AHUs and all your HVAC equipment, making sure that there is no leakage in the frame is sometimes more important than upgrading your MERV rating. You can always go beyond if you want. And again, as we mentioned, you can go to a higher than MERV 13. You can install HIPAA if you want. Even gas phase filter, as we said, at this time, Guideline 44 is leaving the gas portion as optional, but we are now, the committee is still meeting and we're looking into adding more requirement about the VOCs and the gas phase filter, carbon filter, or even going into the reactive cleaning. When you do that, I mean, obviously you have to make sure that your HVAC system, especially for example, your fans and your VFDs are designed to handle the extra pressure drop if you want to add more filtration. And of course, keep in mind that extra filtration will always come with extra energy usage. Now, assuming you can't have your main or your house system deal with wildfire smoke for a reason or another, then when the last resort will be to deploy what we call portable air cleaners. These are, if you want, maybe you can use those as well for if you want localized filtration. And typically to do those, you'll have to purchase them in advance. I mean, if you wait until the wildfire smoke event hits, you probably won't be able to find them. You have to make sure that they don't generate ozone because some of them do. One of the caveats is that their rating is still residential. They're still regulated by AHAM and using a metric called the CADR, the Clean Air Delivery Rate. Typically for wildfire smoke, AHAM recommend 1 square foot of CADR per 1 CADR per 1 first foot of room. So basically, if you have like a 120 square feet exam room, you will need to pick a portable air cleaner that's like 120 CADR. If you have a new project, we have recommended to some owners that you may need to have more power outlet in the areas where you can deploy portable air cleaner and you need a place to store them. In any case, the deployment of PAC, especially in a healthcare setting, need to be coordinated with the infection control, especially in sensitive areas where there is a pressure requirement. You don't want your PAC to affect any code-required pressure requirement. Now, we're trying to get to sum this up. I mean, for healthcare facilities, why we are worrying so much about wildfire smoke. And the reason is that it's very difficult to evacuate healthcare, especially in acute care hospital. This is why it has to continue operating, even if the wildfire smoke becomes intense. And even the ED department have to continue operating to provide basically healthcare to the firefighter and the affected communities. Hospitals also are among the facilities that will have terminal filters like your HEPA filter in your compounding pharmacies or in your ORs. And these could load with wildfire smoke, even if your house system have MERV 13. And as I mentioned, some spaces in healthcare facilities will require certain pressure, positive and negative. So you have to check with the infection control, especially if you want to do any modification or add any PAC to your OR, your NICU, even your HAMA and oncology unit. All of these special systems have to be reviewed with infection control before you implement any pressure changing or adding PACs in these spaces. Now, when we talk of filters, a lot of the people really just focus on HVAC, but there are more than HVAC filter in buildings, especially in hospitals. And I remember when we had the wildfire smoke back in the 2020-21, there was a hospital actually that lost their medical air just because the filter on the intake of the compressor was clogged with wildfire smoke very quickly, and they could not find a replacement. So this is why we recommend you have ample of spares of those filters, and even you can have a duty standby filter on the air intake. Even I've heard of a hospital that have issue in their even NICU incubators. They realized that the NICU incubators, where you put the newborn babies, they have actually HEPA filters, special type of filter in them, and those filters, when there was wildfire smoke, they were loaded with wildfire smoke, even though the main system was filtering, but there were still some particles making its way there. And I mean, luckily enough, they were able to. Some other of their facilities were not impacted with wildfire smoke, so they were able to divert some of the resources, some of the filter back. And again, keep in mind that the babies are, the premature babies are one of the most at-risk people because they have undeveloped lungs. And now we get to what I call the triple Murphy law. If somebody, asked me, like, I would say now, 7 years ago, I want you to design a healthcare facilities that at the same time will handle an earthquake, pandemic, and the wildfire. I would probably maybe at the time, 7 years ago, not sure if I will laugh, but probably I will be like, seriously? I mean, these three is extremely unlikely, at least from an engineering perspective, to happen at the same time. But, 2020, it's the year that no one wants to talk about it. Everybody know what happened in 2020. But during the 2020, during the pandemic, we also had, from in the fall of that year, we had also wildfires. And of course, we are in California, so there is always earthquakes. And again, so beginning of the year when the pandemic started, again, we didn't understand COVID that well. So the tendency was, or the advice we used to give, go to outside air, 100% outside air, and then the wildfire hit. And then the wildfire hit, you have to minimize outside air. So what do we do now with pandemic in a wildfire? Do you go 100% outside air or 0% outside air? It wasn't easy at the time to give an advice. Obviously now we are better prepared. If you join us in session 4, I think we're going to talk a little bit more about infection control and actually 241. And, we come to see that, we don't need 100% outside air for a pandemic mode. And so this was the answer now. You don't go to 100% outside air. You may have to increase your outside air, and then you have to filter it like you've heard here. And that's basically the solution of what to do if you have a wildfire in a pandemic. So how about the future? So wildfires, I mean, there is no doubt now, it will be a continuous threat. It's happening more and more. The intensity is increasing and the frequency is increasing. So we have to design our building and how our healthcare facilities to be ready for that. Obviously, at this time, the guide that you've seen here is still not code, but there is it's a best practice, but it's a good best practice. And even if you are looking into LEED version 5, for example, there is now, which will be deployed soon, there is a strong emphasis on the building being resilient. And one of those resiliency measures is to manage wildfire smoke. And if you apply guideline 44 and have smoke readiness plan, LEED version 5 now will give you 1 point if you do that. And that will be the end of the presentation. And now we're open it up for answering any questions you have.
So just, Abdel, thank you. So just real quick, you should have a tab in your browser or your with the format you're in this meeting to put questions in. There's a chat and a questions, so just recommend you to click onto the questions button at the top right and add any questions. We do have a couple there already. We're happy to answer those for you all. I would say we'll start with the couple questions that we have already, and we'll work from there. So first question is, can we use a duct smoke detector to warn of wildfire conditions? I would say traditionally, most commercial duct detectors we have not seen be tremendously effective in detection like we talked about in this presentation. They typically focus on particle sizes that are a bit larger than what we've talked about. But Abdel, have you seen anything other than that?
No, that's spot on. I haven't seen it being used. Actually, the challenge I've seen some of the building actually, which is the duct smoke detector that's code required being triggered by wildfire smoke and not by a building fire. So it was, we had a few buildings going into this, but now I haven't seen any duct smoke detector being used for wildfire smoke detection.
Great. The second question we had was, when will the gas phase filtration requirements likely be added to the code? Abdel, do you want to take that one?
Yes, I can. So so now what the Guideline 44 committee now is focusing is on the ultrafine, I mean, science. There is science now coming up that, wildfire smoke is not only PM 2.5, it can go actually to PM 0.1, and how can we deal with these things? And I think we will wrap that aspect in the coming 1 or 2 months. And so probably after that, I was going to propose to the committee to start looking at gas phase filtration. And so I'm guessing maybe later in the year. And again, that's part of an ASHRAE guideline, and ASHRAE work in a 6 months increment. So I don't know how long it will take, but that's one of the future topic that the committee identified that we have to look at.
Great. We had a more procedural one asking about whether this presentation will be available for future use. Yes, I believe it's going to be listed on OSHPD's websites and should be publicly available for anybody to have. Maybe at the end of this event can provide some feedback to it as well as far as location. But the next question we had was, what was the reason for not putting the PM 2.5 sensor in the outside air intake? Abdel, do you want to grab that one?
Yeah, and the reason was that they are not rated for such a high velocities. I mean, again, outside air intakes are not. Usually they don't have high velocity, but still, if you can find one that's rated for that velocities, so the concern is that the particle would just pass through without them being detected. Maybe in the future they will develop maybe duct-mounted PM 2.5 sensors.
Great. Well, that was the last question we had in the chat, at least so far. So if you're waiting to push send, please do so now. Okay, we had one just come in. How is the filter load determined pressure drop visibility? I'm not sure. I guess that would be more for the change out, the filter loading we were talking about for change out. Sorry, just trying to infer. Abdel, you had talked about that on one of your slides about filter loading and really more kind of determined by weight. I mean, typically it's also pressure drop through that filter. That's you're trying to change out a filter at a specific point in time when it still has effectiveness and it's still able to be utilized. There's also a balance not only with particulate loading, but also obviously the effectiveness of the filter to take out particulates, but also energy usage from additional pressure drop through that filter if you continue to load it more and more.
No, yeah, no, you're correct, Mikael. I mean, we have in Guideline 44 like a detailed equation if you want to go into the details and estimate. The key, as I mentioned, is a metric that's not easy to obtain from filter manufacturer, which is the dust holding capacity. You can obtain it, but it's not a readily published metric because this will tell you how much a filter can take before it fails. And again, you can use that in the equation and estimate, but again, comes back to, like you said, to pressure drop. I mean, obviously, when you have wildfire smoke, your normal schedule will not apply anymore, like 3 or 6 months, unless you are like very, very far from the fire, and maybe you have a good wind direction that's not affecting your outside air intake. But other than that, we recommend that you check your filter very, very frequently in a wildfire smoke event.
Great. One other question that just came in was, how about the use of carbon filters for wildfire? Have you seen those be used successfully, Abdel?
I mean, yeah, I mean, we've used, I mean, obviously carbon filters are one of what's called the physical, they work on the absorption. So they've typically been used like on kitchen exhaust when you can't bring the smell from your kitchen to an acceptable location in your building. You can add carbon filter to those. And as such, in the same context, you can use it as well on wildfire smoke. I haven't seen yet being tested on wildfire smoke and the efficiency. Obviously, I've seen as well some what we call reactive, like those other technologies, whether being PCO or needlepoint ionizers. Recently, I've seeing some vendor actually start testing their filters, especially the PCO's one. And again, I'm not endorsing any technology. It's just that happened that specific vendor tested their filter on wildfire smoke, and it shows some good reduction in VOCs. One of the next actually tasks that I'm working in parallel now with Guardian 44, which is to develop a test method for filters for actually wildfire smoke, because if you look at the MERV again, going into the details, the MERV test, when you see the filter is like MERV, what does MERV, how did they obtain the MERV rating? Is that basically they use organic dry salt, which is the KCl, and they basically spread that salt into the filter, and if you have 100 particle coming in, and only 20 comes out, that's 20% filter. This is how they do it. The thing with wildfire smoke, well, one, it's organic. KCl is not, it's inorganic. And number two is wet and sticky. So it's the MERV rating is, I mean, we started to realize may not be the best way to rate filter for wildfire smoke. Same thing apply for the gas. So maybe in the future, and again, that's the far future, we could have a new test method for wildfire smoke for filters.
Yeah, that makes a lot of sense, and it kind of speaks to another question we have here, which is the loading for PM 2.5 particulates visible on filter media?
That's a good question. It depends on your proximity to the fire. The PM 2.5 itself is likely not visible, but the ashes, I mean, PM 2.5 will stick to ashes, and then those ashes will be visible. That picture I saw, you will see them as black soot. That depends on your proximity to the fire. If you are far, probably you will not see them visually until the filter is very, very loaded. If you are close, you will see them. You will see your filter getting black very, very shortly, very quickly.
Yeah, that makes sense. Okay, another question. Hospitals often have negative and positive pressure isolation rooms. If we want our whole facility in best case positive, what advice can you offer MEORs to design these delicate pressure relationship rooms? So I think to start out with, I think we want to, you know, part of the logic for having the building be positive is really positive to exterior, right? So we want to look at the location of the points of entry into the buildings, not so much from an air intake perspective, but we talked a lot about doors and windows and other openings into the building. In most cases, the isolation rooms being talked about are certainly have some proximity to things like windows, but are likely more internal to the building. So when we talk about building pressurization, a lot of that focuses on what is that total pressure relationship as it interfaces with the envelope of the building as you move around it, and so our advice would be these are not hard and fast rules that never get broken. These are approaches and guidelines and specific factors of proximity and competing risks to specific room types should be considered on an individual basis. Anything to add to that, Abdel?
No, I think you answered well.
Okay, well, with that, we are getting close on time, and we really, really appreciate all of the thoughts and questions and input from the group. And with that, I would turn it over to Yvette to close us out.
Thank you, Mikhail, and Abdel, and Samantha. This brings us to the end of our presentation, and we hope you all found this webinar to be helpful. In the chat, you may see that I put a couple links. So the design guide that they've been speaking on is in there, the link. Also, if you have any questions about this presentation, send them to HBSB support staff at hci.ca.gov. And for more information and to register for that third webinar they mentioned earlier, called Design Guide, Power Resilience, Regulatory Compliance, and the Future of Healthcare Infrastructure. I put the link in there for the webinars page that has more information on how to register for that. It's been a pleasure being with all of you today. Thank you so much for what you do and for doing your part in providing access to safe, quality healthcare environments throughout the state of California. Thank you so much again, everyone. Take care and have a great day.